Hello, I'm Dudley Robinson and I'm here at the ICS 2023 in Toronto, and I'm fortunate to have Emily with me, and we're going to talk a little bit about why Emily's here at the ICS and also what she's been up to so far during the meeting and what she's particularly looking forward to. So I think maybe Emily, if you could introduce yourself first.
So hi, my name's Emily Carter. I'm a clinical research fellow at the Royal Unit in Manchester, and I'm also a clinician, so I'm sort of in my ST7 year of training, so towards the end of my training, and this is my second time at ICS. And I have given 2 presentations this morning, one of which is work from my MD, and one was which work I did previously.
So you say this is your second ICS, so which previous ICS have you been to?
I came to ICS at Philadelphia, that was in 2018, and that was, I presented a video at that time with some videos, mesh video, and some work from a previous unit where I worked in Oxford. I presented some work from that as well. That was a short oral presentation, and this year I seem to have worked up to doing some longer presentations, so that was quite nice.
And what do you particularly remember from ICS in Philadelphia, or what brought you back? Why are you coming to ICS again?
I think it's a nice environment for trainees and, well, probably everybody, but from my point of view it's got an early career professional network, which is nice, so I know colleagues that come. But I also quite like that it's an international focus, so when you end up I'm doing my own research project, you end up in quite a niche area, so it's quite nice to come and collaborate with colleagues from all over the world. And I think it's been quite well organised and things like that. So I've enjoyed coming.
But I remember my own boss always saying to me that when you come to some big meetings like ICS, if you're actually speaking and you're presenting your paper, then it makes you feel much more part of the meeting, doesn't it? It really makes you feel part of the whole system. Yeah,
and it's nice that people discuss things with you, not only in questions but often afterwards as well. They come and talk to you, and there's, like I said, there's the early career professionals network, but there's lots of other opportunities to network with people and discuss your research and get new ideas, which is great.
And I think the other great thing is that you get to meet people who are urologists, urogynecologists, continence nurse specialists, paediatricians, so it really is multidisciplinary and brings it all together.
And that's great. And like I said, I've worked with even methodologists as well, and sort of systematic reviewers here as well. It's a big mix of people, which I enjoy.
But I think one of the things that when I first came to ICS in 1999, one of the great things that I remember is seeing those people whose names you've seen in textbooks or on the posters, and actually getting to meet them, talk to them, and perhaps ask them questions as well. Yeah, and putting names to faces, because sometimes you read someone's paper or their work, but you get to actually hear them speak or meet them. See what they look like.
Yeah, see what they look like in person, or see if they can dance at the dinner, so it's good to know.
So with that in mind, what have you been doing today? What were your presentations on this morning?
So my first presentation was the first of the conference, which was exciting. So that
you always know it's an important one. It's in the big slot, first the conference.
Abstract number 1.
Prime time.
I won a Best in Category prize as well, which I was pleased because it's the work that I'm doing now as part of my MD. So it's we were looking at whether in women who have an obstetric anal sphincter injury, which is known as an OAC, whether they that often happens in their first pregnancy. So and then women get pregnant again and they've had a vaginal birth, but they've had an injury. So whether women have a vaginal birth or a caesarean section next time, and one of the main reasons we would discuss the caesarean section with them is to reduce their risk of anal incontinence. So I did a systematic review and meta-analysis where I looked at all the data that we have currently published available on whether caesarean section prevents anal incontinence in women after obstetric anal sphincter injury.
And what did you find?
What did we find? We don't have much evidence to support our current practice. In fact, we know that because our guidelines are based on expert opinion and they haven't been updated in several years. And although we have some really, great groups out there, but the actual projects are, maybe not always well designed to answer the actual research question, this particular research question, which is what we need to do to counsel women. So I guess my work will hopefully go on to provide more data for that and whether we need a bigger trial or what we can do.
This is an incredibly important clinical question as well, isn't it? I mean, the method of delivery of someone who's had a previous anal sphincter injury And I know some units use scans, some units use anorectal physiology, but I don't think we know a definitive answer, do we?
Yeah, and we don't, everyone does something different, and a lot of people publish data from their unit, but whether that's applicable to other units, and what subgroups of women, is that women with no symptoms, no injury? Is that women with no symptoms but an injury? Is that women, with symptoms and an injury? And most of the data we have is on a group of women that have symptoms and no symptoms together, a mixed group, but then that adds the issue of you've got women with symptoms and then you're looking at long-term symptoms as well, and that's very linked. So it's very difficult to actually unpick the data, and we probably do need a higher quality evidence, a trial or something, just to answer the research question.
I must admit, because obviously I was there listening to the paper, what fascinated me was I just thought it was going to be clear that caesarean section was protective as compared to a further vaginal delivery, and that certainly wasn't the case, was it?
Yeah, we don't have that data, so we advise women, and some women, they want another vaginal birth, and we're talking about caesarean section, and they ask what is the evidence, and it's very interesting, we don't really have clear evidence, and we haven't, as urogynecologists in our profession, we haven't really come up with clear evidence that a caesarean section in a future birth is protective. So, if a woman says, well, I've had an injury, is that damage already there? Is that going to cause me long-term problems? We don't know whether caesarean section will prevent any further issues, so particularly in the long term. So I think it's a really interesting question, quite hard to answer.
And I also got the impression that you felt that a possible co-founder in the study was the fact that those women who maybe had symptoms already were more likely to have a caesarean section rather than a trial of labour.
And these are non-randomised studies, so obviously, a woman who has symptoms is more likely to want, or maybe have an injury, or more likely to have reasons to want a caesarean section, and then they are also more likely to have long-term symptoms. So what you're doing is saying women that have symptoms are having symptoms in the long term, and women that don't have symptoms maybe are less likely to have symptoms in the long term, and the mode of birth of having is related to their symptoms, not necessarily to the long-term symptoms aren't necessarily related to the mode of birth. So there is that confounder there.
So I guess the question that we always ask, where does this research go? What are you going to do next? When you come to ICS next year in Madrid, what are you going to be telling us about?
Well, this is the very start of my MD, so the first thing I did when I started my MD was to do a systematic review to look at the evidence that was available and how to answer that question. And I think what I'm realising is we need quite a big study, like quite a high quality big study to answer this. And it's so I think my MD is going to be preliminary work to see whether women want to be randomised. Could we do a randomised controlled trial? Would clinicians want to randomise women? And then we'll go from there really in terms of whether we can make it bigger, get funding and that sort of thing. So I guess I was interested to see how it would be received here, and what sort of questions I'd get asked, and because it is quite, in some ways it's quite interesting as a urogynecology research fellow, as you come along and you do literature review. I've got clinical experience, I come up with my project, in something that I think is a useful area, and with my supervisor, but it's not like, we've come up with this project ourselves, so it's quite nice to get that sort of validation of how useful is it.
It's a really important area, and it's asking a really important clinical question about what should happen.
And it was, it's quite useful with my stage of training that I've sort of had that clinical experience already and been able to formulate my own research question. I found that personally quite valuable. So
and I think in the first session you gave another presentation as well, didn't you? So two in the prime time session.
So my second presentation was a big Cochrane systematic review I'd done in collaboration with Cochrane Incontinence, and that was work I'd done before I started my MD in Manchester, and that's work's been going on for a few years, but it's finally getting to the point where we're publishing it now, and that was looking at all the evidence we have for single incision slings, which is a short mesh sling, and comparing the evidence for single incision slings with transobturator slings and retropubic slings, and also, which I didn't quite have time to present on, autologous fascial slings and mixed groups as well. So the full review will be coming out very shortly.
And the take-home message for everyone watching live?
The take-home from that one is single incision slings are as effective in terms of cure or improvement of incontinence, of stress incontinence, as obturator slings, and probably the same as retropubic slings. Some of the data we don't have good long-term outcomes for, but in terms of things like pain, that's less common with single incision slings than obturator slings. and things like mesh erosion may be less common in patients who have similar things as well. But again, it's interesting that we had so many trials included in the studies, in this meta-analysis. So we had 62 trials, and only I think 8 of them had data published over 3 years. So again, it shows that as urogynecologists, we could do with publishing longer term outcomes from women who have mesh.
Which I think brings us nicely on to the last paper in our session this morning. And if you want to watch this, I'm sure it'll be available on ICS TV, which was looking really at a minimum data set for these sort of studies and how you look at studies for continence surgery.
And that would be really useful in future design of trials, is that when you come along to meta-analysed studies, if you can combine them, otherwise you restrict what you can combine together if everyone's done different outcomes or that sort of thing. In fact, we tried to be as inclusive as we could with our study. We looked at subjective cure or improvement of incontinence and tried to collect as much data as possible. But it would be good for the future if we could agree as a profession what we want to research. That would be helpful.
So is that you done now, or do you have some more presentations?
No, I'm done with private presentations. I submitted my 2 abstracts and I'm done before 10 o'clock on the first day, but that doesn't mean I'm really done.
2 abstracts, 100% acceptance, and in the first session.
But it doesn't mean I'm done, because I'm going to go to all of my colleagues' presentations. I'm going to be participating in the early careers professional tonight, and I've got my eye on a few sessions I want to go to, such as the mesh excision session, the stress incontinence session. I've got a few things earmarked.
So you've got some sessions lined up already. Anything else you're particularly looking forward to?
Toronto is a very nice place to come to, actually. I've never been to Canada before. Everyone's very friendly and nice, so I'm enjoying just being here, really.
So maybe a bit of sightseeing around Toronto as well?
Maybe a bit of sightseeing, yeah, if I can fit it in.
And any thoughts about next year at ICS? It's going to be in Madrid in 2024?
Yes, well, if I have any preliminary data from my MD, so my MD is going to hopefully be a series of smaller, mixed methods, so I might have some data from that to present. Next year, we will see.
And I think, again, for someone perhaps watching at home, what would be your top tips in terms of getting an abstract accepted here at ICS, about how to write one, why ICS rather than some of the other big international meetings? What made you?
In terms of the abstract, it's different in terms of it's basically 1,200 words, which is quite a significant amount of words. But this is a good conference because your abstracts get published, so it counts as one of your publications. You can submit a couple of figures with it as well, and if you're interested in submitting an abstract, I would get people involved, early on board, your supervisor or your project. And I've started submitting smaller things that got accepted, a few years ago, and then you work your way up to getting a bigger project. So I would submit what you can, because there are poster sessions, and there are video sessions, and there are shorter communication sessions as well. So there is lots of opportunity.
And I think, having been on the scientific committee in various organisations, we always try to be inclusive. So if you are thinking about submitting to ICS, please do. And hopefully you'll get your work accepted, and you could be sitting here on ICS TV live like Emily this year. So I think we'll leave it there. Emily, thank you so much for spending some time with us.
You're welcome. Thank you.
And enjoy the rest of your time in Toronto.
Thank you very much. Thank you.